today. So welcome, NUR203 Pediatric Nursing. I am Professor Bogart. I am the lead pediatric professor also. In case you need anything, you come to me, right? Well, what happens if you can't get a hold of me? You need to get a hold of Dr. Brown. Don't be upset or worried that I'm going to be angry that you call Dr. Brown. In fact, I'll encourage you to. If you don't have what you need, she is your next step. I don't get in trouble, none of those things. We are a team, we work together. If I can't, she does. She can't, I do. Okay? So don't be afraid of getting a hold of someone when you need somebody quick. I've been with Fortis since 2017, where I came on at Cutler Bay. I was teaching pediatrics and pharmacology. So I've really got a good pharmacology background because of several years teaching that. I'm also your dosage calculation person to go to. If you need someone to make sense out of it, I'm the person. One of the things when you come and sign on, I just got a Zoom user come in. I need your name. Oh, there we go. See, somebody knew me better, Riddle. Thank you, Crystal. I know who Crystal is. So
Hello,
I've been
ma'am.
around. I've been around Fortis for a while, so I know the ins, the outs. I know this term. I know what you're going through, and I think I could try to help you through it a little bit easier. I know when community has projects due, and I know MedSurg changes the exam dates all the time, but I know that when you get them, they're really rough, and I know there's a lot of that with there. How do I teach? Well, I teach a PowerPoint, but it doesn't mean I read a PowerPoint. I'm going to give you the gist, and I'm going to make understanding of what that PowerPoint says. It's not just going to be reading intussusception is when the telescoping of intestines. No, I'm not going to say stuff like that. I'm going to tell you what a child looks like, what he's going to feel like. I'm going to make you experience what that diagnosis is so that you can remember it in the future. That's the only way I remember things. When I'm done with my PowerPoint, I always do a Kahoots. Now, starting next week, I'm going to be doing something a little different, the same, but different. And it's because of a student who recommended it last term. I tend to do the PowerPoint, all of them, for whatever chapters, and then I do the Kahoots on all of the chapters. I had a student say, it's just too much, too much, too much. So she said, how about if you did the PowerPoint with a Kahoots that follows that chapter right away, then do another PowerPoint with the Kahoots that follows that chapter. It breaks it up. It gives your mind, a chance of stop listening to all this information, death by PowerPoint, right? It gives you that chance now, just little bits and pieces. And I think it's going to work well. And that was a suggestion from a student. So I do take anything you tell me and I think about it and say, that was a great idea. So I've already done next week. It's already ready to go. I had to do some work to get there, but it gave me another revision of the course, and it's actually going to help you in the long term. So thank you to that student, whoever she was, right? We will do a PowerPoint, and then we're going to be doing the orientation PowerPoint. We're going to go over it briefly because you just heard it this morning or you just heard it in community. So I'm going to go over those concepts within it that you really need to understand me by. And the biggest word that you're going to hear me say is communicate with me, talk with me, let me know what's happening before an assignment, a test, a quiz is due. I can help you before, I can't help you after, okay? And I am here to help you if I can, all right? So we'll be doing PowerPoints, then we'll be doing the Kahoots, and that will be our class, and we'll do it that way. Now, today's class is going to be probably your shortest class of the term. You will be getting out a little bit early, only because I know as we go on, especially for instance, week 5. Week 5 is respiratory cardiac. It is a lot of information, and I don't want you leaving here not knowing your information. So you might get a shorter break that class. But all in all, you'll be getting, all the time you need into pediatrics. So any questions about anything so far? Okay, let's go to our first PowerPoint. This is the one on, the rules, the regulations. Let's talk about online nursing and expectations. Now, we all have approximately the same PowerPoint. We all make our own little changes to them. So I'm not going to be going over and reading this through to you. We know what online nursing, online studying is you come to class on Zoom instead of going to a classroom. But all the assignments, everything are just like if you were on ground. If you need anything about questions about anything. Now, I've been working in pediatrics since 1983, where I started in a newborn ICU. I've worked newborn ICU. I've worked cardiac ICU, my absolute favorite in the newborn, in the pediatric world. And then my last 10 years was in pediatric ER, the trauma ER. That was at Nicholas for those who are in Cutler Bay. It's a huge facility, level 4 trauma center. I was the trauma junkie. It's what I really thrive at. I'm the calm in the storm, and they used to love to have me there. So I've got a lot of experience. If you have any questions, ask me. I might be able to know, or I know where to look it up. And if I don't know, I'll say, I don't know. I don't have to know everything. I just need to know where to find it, right? Or where to look it up or who to ask. And that's how you're going to be as brand new nurses. So again, first person you talk to is me. Here's my email and here's my cell phone number. And it is my personal cell phone number. Now, what all I respect for you to do with my personal cell phone is don't call me too early in the morning. I'm not a morning person. I have rheumatoid arthritis. My brain does not think well in the morning, or either does my body. So give me a little bit of time in the morning to answer that phone call, or send me a text and I'll get you back as soon as I can. The cell phone is for those emergent things. Like I've got these 3 hours to study, to do this, to do that, and I need to know an answer so I can get it done. That's the urgent. I consider that urgent if that's what you're calling me or texting me for or emailing me for. And you can, please do it. I do answer on weekends. I'm always looking to see if there's messages. So send me messages. It's usually pretty quick. I'll get back with you. And then I told you Dr. Brown is the next person to get a hold of. This is her email, and make sure that you put her whole first name in. There is a D. Brown in the Fortis system, so it will go to the wrong person. We found that out when we first started online, and her as the dean. So yes, her whole name will be her email. And that is her phone. You'll be surprised. She answers it early in the morning, late at night, and she's now positioned in Wisconsin. So she is Pacific time, but she is up at 4 a.m. She doesn't go to, I don't know if she sleeps. She's a very, very dedicated woman to this position. Any other problems that you need concern of? Your LRC can help you with any sort of programs you're trying to get used to. I know that we do have those new ones this term. Actually, they're going to be a lot of fun. Actually, you're going to enjoy them. Again, with communication, being polite, being professional at all times. And this whole thing about no messages in caps, it's like you're yelling at them. I didn't know that until I was told that. So, but anyway, just be considerate. I'm going to be considerate of you. You be considerate of me. It's basically what we always should be with everybody all the time. So, talking about our attendance. Now, your attendance is, of course, when you come to class. We know 1 minute late is 15 minutes of time. 1 minute late going out early, and I don't do 1 minute early. It would have to be 15 minutes early that I would say, I would take the time off for. The other way you get attendance is by posting into Canvas. I've already noticed somebody's posted all NCLEX questions. The problem with that, you have to have 2 areas of contact in the Canvas shell every week. That's your other part of Canvas, the attendance in your Canvas shell. So you have discussion questions, you have your NCLEX questions. If those are 2 points, if you've already done an NCLEX question, how are you going to get 2 points in there? So be very, very careful. One person did it already. Be careful. All right. That's all I'll say. I mean, you've got it done. It's just been busy work for you. Have you learned from it? That's my concern. I like them done right before the exams because it's like a test. Do I know this stuff? Discussion boards. There's always this thing about what do they do? How do I do them? I don't look at necessarily the Wednesday post. I look at you've done a post and you've responded to two of your peers, and that's by Sunday. I know sometimes Wednesdays is that day of the week you don't remember. Just again, this is one thing I'm giving you is till Sunday. You have to get all of your discussion questions in. So you don't have to be going crazy. Oh, did I do it again this week? Okay. Also note your syllabus is your Bible for due dates. What week are they due? Go to your syllabus, and it's right in your Canvas shell. Okay, professional conduct, and this is cheating. This is plagiarism. This is using forgerizing things from other people. Now, it's always been done. It's always going to be done. And the only thing you're doing is you're hurting yourself. And in the long term, you're hurting a patient in the future. Do you really know your information to really take care of that child? Now, I know how hard school is. I got a PhD and I'm just finishing a dissertation. I know what it's like. I know those things that, oh, it would be easier to do it this way. But again, it's not what will give me what I need to be the best nurse or the best teacher that I can be, is to do those things. And I will tell you, they're very, very strict on plagiarism, using plagiar checkers, and checking all of those sites that are plagiarism sites, that Sudoku, Coursera, Stuvia, and there's many, many more. And they have a team just watching them. So be very, very careful. If you're using one of these things, if you change up the words, make them to your own, that's a different thing, because that's what we do with references. And we go into an article or a book and we're looking, right? We change up the words, we use it. You can use that as a guide, but not as your work, okay? Make it your own. So work is due from Sunday to Sunday, all right? If you get it in on time, you'll get full credit. After Sunday, it will be a 10% deduction, unless, let's say you were in a hospital, your mother's in a hospital, your computer died, it blacked out screen and it's being repaired and you don't have any car. I mean, I've heard everything, everything, everything. And I understand life happens. Tell me before it's due, and I will give you that extra week to get it done. But you have to communicate. Again, communicate. Attendance is coming to class, but as I said, it's always posting on the Canvas shell. So there's two types of attendance. The way that you come to class, make sure that you're on camera at all times. What I see is students tend to close to the side, especially during exams and quizzes. You get the faces missing. Do not do that, especially during your exams and your quizzes. I will be posting, hey, get your face on camera. I can't see you, or your screen went black, or get on camera. I'll give you a chance or two, and then I'll remove you, and you'll get a 0. And I do not want to do that. That's the last thing I want to do. I want you to have every chance in the world to get the grade that you're supposed to have, okay? Now, nobody can be in a car. I don't care if you're in the back seat, front seat, passenger driving. It is a safety risk, okay? Another thing I see a lot of is ceiling fans. Please don't give me shots of your ceiling fans for the whole class. It's not telling me that you're there. It's not that you're present. I do attendance every day. You know that you will be getting those notices. Dr. Brown's assistant, Deb Northrup, will be sending them. One thing I can tell you, if you're ever late or if you ever miss class and there's a reason why you're missing, if you can get any documentation of that, have it. If you have documentation that covers the time missed, it may be looked at and it might be said, okay, you're not going to have that 20% and that whole full letter grade dropped down one full letter grade, okay, your final grade. So again, keep that documentation. And again, notify me what's going on so that I can say, hey, you were in the hospital. Okay, did you get a discharge note? I mean, anything I can have. It could be you had a car puncture in the middle of the highway, but you have a um, a sales bill of sale that had a new tire or a plug of a tire that day. I can, okay, it probably happened. I can make sense of stuff if you give me what you can get. Okay. Now, how do you be successful? And earlier, speaking to one student, you've got to be organized. What is due every week? Oh, everybody does things different. I'm a paper girl. I get one of those big paper calendars and I write on it. But I know as students, today you're younger, you're more technology, person than I am. And you're going to be putting your calendars out, making sure you get them done. I do send reminders on Saturdays for the first couple of weeks to remind you, hey, you forgot that NCLEX. Hey, you forgot that discussion question. Get it in. I'm wanting to make sure that you get the best possible grade you possibly can. You have to look at your shell. We know what to do with that. And this is the biggest one. Keep in contact with your instructor. The other thing is make sure that when you come to class that you have your plug and that you're charged for the whole class. I can't tell you how many, even quizzes, their batteries are going to run out, or they send me a message, my battery is going to run out on an exam. So then they have to zip through it quick so that the battery doesn't die. That doesn't benefit that you at all. Make sure you come prepared. And as you're doing that exam, because you have the ability to choose where you're going to be, make sure it's a place where you're free of distractions if you can. And I know sometimes with families and children, that's difficult. I've had students lock themselves in closets, washrooms, and basements, in order, and attics to try to get away in order to have it quiet for themselves. My office hours are when you need me. So if you need me before class, I could be here before class. If you need me to stay over after class, I can stay over after class. Whatever you need to help, which wherever I can offer that help, you can ask me, I will be there. If there's a problem with you and learning and understanding, I don't do these quote organized tutor sessions. I think that I can have something geared to you. If you're telling me, I really am not understanding anything about the heart, can you help me? Of course I can. And I will sit and I'll go over that with you. And the other thing I want you to know, I'm not that professor that once I get you online will keep you there for an hour or two. No, your time is busy. If I can get 15 minutes, if that's what you can give me, that's what I'll take. And I will give you the best 15 minutes I can. All right. Grading. 80% is your quizzes, your exams, and your HESI. After that, it's 20% is all the homework. The one thing I'm telling you about the homework is number one, as I said earlier, don't hand them in too early. Your NCLEX questions are open. I did that there so that you could look at them, but not to do them and put them in quick. All right. It's many of you do what the student did, have them done. Just put them in every week that they're supposed to be due. It's the best way to do them if that's what you want. All right. When you do your homework, try to get the bare minimum of 78. Some of you students get hundreds all the time, and I applaud you for that. It's the best way to do it. But getting a 78 will guarantee that your homework will not fail you. Do you know every term, I have at least 2 in the pediatric program that will fail pediatric nursing because of homework. And they had good exam, HESI, and quiz grades. That's crazy, isn't it? Just because of homework. So please, when you're doing the homework, sometimes you just want to get it done, right? Get a 78. Then you know that's not going to bite you in the end when your grades are too low and you possibly could not be successful. Homework grades are off. They'll be turned on in week 6, and then I'll turn them back off in week 8. And that's just to show you how homework does affect your grades. We know about grades, and combined, you need a 78. Now, you're taking a exam, you're taking a quiz, and making sure all of your equipment's there. Well, what happens if all of a sudden your computer screen goes black and you got nothing, and it wasn't this or that or stuff that you could have prevented? What do you do? First of all, stop the exam, take a deep breath. Don't worry, you can pick the exam up where you started. That's first of all. Second of all, notify me immediately, because there is timestamps on not only exams, but on quizzes. And I can go back and look at when you notified me, when that happened. I can correlate the times and say, okay, we need to restart and give it to you because there was equipment failure. Okay. And then usually pictures of the computer black screen. Also, again, is some sort of documentation that can help me. KGA quizzes. They are not, you cannot make up a quiz. But let's say in the end that quiz will pass you and you have an excuse why you couldn't be there. You can ask Dr. Brown, and she most likely will allow you to take that quiz again, okay? But we won't let it done during the term. It would be at the end. Quizzes will be at the beginning of class. And next week's quiz is on this week's material. So it's very general type things. And if you study the Kahoots, you're going to be just fine, okay? Exams are through ExamSoft. One of the things you need to do is do the ExamSoft study exam, the practice exam. Why do you want to do that? Well, what if something happens the first day you come to class to do your first exam, and the exam won't load, or this and this happened, and you didn't do that practice exam? If you had started an exam or things had happened, it's not going to benefit you as well as if you had done the practice exam. Okay, because that's one of the first things that is asked. Did they do the practice exam? And I can say, yes, they did. They say, okay, then let's reset, let's redo another one, let's give it to the student. So again, you can see how, number one, doing what you need to do and communicating with me, we can get things done for you. Again, it says what I just said. Anybody with accommodations, if you need extra time, I need the letter from Dr. Elaine Foster. I will also send that to Dr. Brown. That will give you extra time on your quizzes, and it will give you extra time on your exams. If you have that extra time in your exams, I need to know so that I can set up a time where we can give that exam with the extra time in. You need to tell me what you and how you want to do these exams, okay? And I will work with you. We know Zooms are proctored. We're going to do all of that checking and, the IDs, et cetera, et cetera. We know exams. Let's say you come to the exam and I look at you and you look pale. You're holding your head and I'm like, do you feel all right? And you say, I have a massive migraine. I feel horrible. I'm going to ask you, do you want to take that exam? And if you say, I really don't think so, I'll say, let's reschedule it. It's okay to do that. All right. If before the exam, you can say, I've been vomiting all night or whatever. I can let that exam be done at another day and time, as long as it's not every exam we're doing that for, okay? If you do not show up for an exam, you do not call, it will be a minus 10% deduction. And you have 1 week afterwards to get it done. And if not, it's a 0. So today is Friday. If you miss today's Friday exam, you have to have it done by next Friday before class. Again, talking before, not after. We know that the quizzes are through Canvas. Specialty exams, HESI, it's only 1 attempt. I've got some great HESI review stuff. I've got 2 100 HESI question cahoots that are awesome. I also do a HESI Q&A on the Saturday before your HESI, and I basically try to help you think of what could be in all these areas, because there's a lot of information. Just growth and development on children is a lot. So I'm going to show you what are those things that you really should know. That's the remediation. I'll have it written down in an announcement for you. We know ID is always there. You need it. And homework. Just homework. Keep yourself organized. You know, follow your syllabus. Whatever your assignment worksheet is, make sure you do it. I've seen students with pink and yellow and green markers and, you know, red checks, and whatever it is to keep you organized, use it. We've already talked about late days, NCLEX questions. I've mentioned them. Yes, they're open. As I said, I like to do them before the exams because it is a quick sort of concept looking at. Do I know that concept? Do I understand if it's X to me in a couple different ways? Another thing, make sure your NCLEX questions are turned in the proper format, and you change it, the exam, print the results, you put it to PDF, and that will be the results. If the first time you send it in, they're not correct, what I will do is give you a 0. No, you're not going to stay with a 0. What that's doing, it's alerting you, hey, something's wrong. I turned it in, I know it's there. Oh, I got a 0. Let me look. In the comments, it's going to show you what was wrong. Did you do the proper NCLEX questions? The first set is growth and development. It's not pediatrics. Okay, that's the biggest common mistake on the first set. The rest are pretty simple. You just follow, you know, is it neurology or GI, etc. But the first one is the one that students forget. They think it's just pediatrics, and you will not get as many questions as you do need. So be careful on that. So if you see a 0, I will give you to the following Sunday to get it resubmitted. So take a breath. I'm not here to give you a 0. Try to get the best grades as you possibly can, of course. I said minimum is your 78 here. And then you have at the end, week 8 is your assessment exam, and week 10 is your practice exam. These are large questions of questions, like an NCLEX questions that you practice right before you take your essay. Most of this Canvas stuff all should automatically transfer over the grades. If it's not there, if it didn't transfer, send in a help desk ticket and let me know so I can follow that up, okay? We do have those new sim charts, right? Those case studies. Just follow them the way that you go through them. And again, they're submitted and the grade should be pushed right over into your grade books. We have one paper assignment due here, and it is due in week 8. Very close to where communities assignment is due also. So what is it? It is 3 sections. First of all, it is pick a diagnosis that's pediatrics, or could be pediatrics. I like to tell you to pick something that you had, your daughter had, your best friend, or you were in the hospital, you saw something and it interested you. You want to know more about it. That makes this less of a chore, okay? Because it can be just busy work. Make it into something that's a little bit more than that. So the first is 250-word APA paper. Make sure you do the citations, etc. If you send me that one in first, I'll grade it. I'll send it back and you can make corrections to get higher grades if you want. As long as you do that before week 8, I will grade it and grade it and grade it so you can get your perfect 100 on it. It is 6% of your grade. It is as much as all of your sim charts, okay? It is huge. So that's part of it. Now, the second part is on the modules in week 8, and it is a assessment form. Most of it is circles, okay? So it looks like 15 pages is a lot. It's filling in who you are, et cetera, et cetera. It goes in through the systems of the body. make sure that you are reflecting your diagnosis. If you say that child has asthma, then the respiratory component might have expiratory wheezing, retraction, nasal flaring, dyspnea, tachypnea, right? Those things would be in that assessment. Also, in the end, the last 2 pages, most important, they go into the theorists and what theorists are they? And we're going to go into theorists a little bit this week, but a lot next week, trying to help you understand them. I think I've gotten it down to that we're a level where I can describe it that it makes more sense for you, because theorists are talking about psychosocial and cognitive, and I'll tell you, I'll figure it out for you, okay? I'll help you understand it. But then it goes into how, because of the child's age, how are you going to approach the care for them? As in a toddler, you might make sure that you continue on their normal routines, or making sure that they have their special blankie there or whatever, okay? And then the third part that I'm talking, the part on this assessment form is NANDA diagnoses. So difficulty breathing related to asthma as evidenced by dyspnea, expiratory wheezing, related to as evidenced by must be there. And that's the assessment portion. And then the third portion is just a short, small. Most students pick a PowerPoint, 4 or 5 slides. Don't go crazy on me. Teach me something. Maybe asthma, you're teaching me on how to give an aerosol, or how to prevent asthma attacks, or how to clean the equipment every night, etc. Those are simple, simple teaching. An ADHD child, how to put up an organizational chart. That's all teaching, okay? Those are the 3 things. So if you can start this the next week doing the paper, you're going to be ahead. But remember, I have to approve the diagnosis. There is a grading rubric there that you can follow, and so do I. And of course, you're going to use the APA format for it, and use scholarly journals that we can. And then this is the last page, and it basically just talks about looking at schooling as nursing care. It's, are you doing what you need to do to get the job done? As in, did you study well for your HESI, or did you gather all the equipment you needed to do that dressing change? It's the same sort of thing if you look at it that way. So any questions about what I want? What's the one word that I want? Communication. Talk to me. Talk to me. All right. I don't mind messages. I don't mind emails. I don't mind text. Don't, just let me know what you need, and then I can help you. All right. Let's go to today's PowerPoint. So this week is a lot of chapters, and it's very overwhelming. And I don't expect you to remember all of these things. What I'm doing here is an overview, pediatric nursing, and what are these things that we're always looking at, examining and researching, the federal government, what are we looking at, and all of those. This first slide is all about healthy people. Has anybody ever heard about healthy people in the governments? They're looking at certain things and they focus on it. Healthy lunches, and, going outside instead of, sitting down and reading, watching a TV or computers. Well, I never knew what this was. And I went back into my school to do my BSN at age 53, guys. And then I went for my MSN, and of course, finishing my PhD. I didn't know what this was. And what it is the government looks at certain things and it evaluates, quote, disparities, which are populations that need extra look at, which could be children, homelessness, elderly, poverty, All of these things are disparities. These are things that need extra help, extra look at. So, why do I mention this? Well, most of you are going to go on for your BSN and MSNs, and many of you want to do your ARNP. It's just the method of nursing today. They want these higher level degrees. You're going to be getting a lot of papers to write. The difference between the associate program and the bachelor program is associate program is mostly testing your knowledge. Bachelor program is mostly writing a paper describing that knowledge and describing it in a manner that is understandable, full of facts. So these are different things that the government today is looking at. I think mental health nutrition is always going to be there. That's why we have WIC programs, right? In order to give food for those under people who really need extra money for their formulas for their children. Other stuff we look at, school age children, obesity, and why do we have obesity next to type 2 diabetes? Well, it's been shown that school age children that are obese have a higher risk of being adolescents and older children that develop type 2 diabetes. So, what would we want to do for that child to prevent that? And this is one of the best ages to do it, school age, and it's teaching these children what to eat, how to eat. Those My Plate things on, the internet, and using them and making fun with it, and making them understand why health is a big problem. Child injuries, unintentional injuries will always happen, any age child. And I think the biggest injuries overall, any child, motor vehicle, because it is infants all the way to us. All of us can be hurt with a motor vehicle, whether we're in a car seat, whether we're in it correctly, wrongly, or just motor vehicles being hitting us. Even think about preschoolers that are now starting to walk a lot better. They are actually going behind cars and getting run over by cars. So that is one of the biggest childhood injury things that are out there. And then, of course, we have the other things that we do. And you're thinking mental health, children. I've seen young children have serious mental health issues, and they're real. They're not kids who are spoiled and having a tantrum type thing, which some people think. No, these children really do have a problem. They can't control what they're thinking and what they're seeing, et cetera, et cetera. So it is a real problem. Now, infant mortality. So just to give you the difference in terms, the first 28 days of life is known as neonates. That's a neonate or neonatals, all right? After 28 days, up to 1 year old, they're an infant. There's a slight difference. You'll hear differences in your reading, so I wanted to point that up. So the neonatal mortality less than 28 days is higher than more than that, because what happens with those less than 28 days of life? Those are the children that are born low birth weight or very low birth weight, right? Those are the ones that are highest risk of dying. Childhood mortality. Again, this is unintentional injuries. We know that the death rate is greater for greater 1 year of age are less than for infants. Because why? Well, infants can't get into all the things that children get into. So infants is just the normal things that can happen. Children can be ran over by cars and climb up your dresser, and the dresser and TV can fall over on them. I've seen these things happen. We know from 5 to 14, that's your school ages, right around, sort of. These are children you can teach, you can groom, you can teach them how to be safe, all right? But then they get to be adolescents and they don't want to listen anymore, right? This is where injuries are a big thing. Firearms, huge. They think that now that they're old enough, they can get daddy's gun and play with it that's in the closet, right? Daddy left the gun in it. And then, of course, now we had a homicide. And that's how those things happen many times. The other thing is you put here, it's number two. Homicide is the injuries with firearms is number one. Suicide will be number two. And it's because adolescents are into their body image. And many adolescents don't like themselves. Too many pimples, too fat, too skinny, too short, too tall, all of those things, right? And because of poor body image, they could get into this depression and it could cause suicide. Other things that can cause morbidity is, again, certain sort of groups that we're talking about, those disparities, homelessness, poverty, that low birth weight infant, there's no defense on that child. There's nothing there. Chronic illness like cystic fibrosis, sickle cell, chronic illnesses. And then foreign born, we don't know everything that's going on with them. And why is children in daycare centers part of childhood morbidity? Kids die because they go to daycare. Why do you think that is? Take a guess.
They get sick often.
They swap spit all day long. Yes, absolutely. Think about what kids do. How do they explore the world? Right there in their mouth. So they take this toy and they play with it. And as good as a healthcare, childcare workers are cleaning things in between, they're still going to swap it. Now, I'm going to say, is it a bad thing to swap these germs as these toddlers and in daycare? Not really. Now, forget COVID, and that's a different story, but normal things. If they get it in daycare, they're not in school, right? And they're building up antibodies and they're building up this defense against it. So by the time they get into school, their bodies are ready to be around kids. They'll stay in school and they'll get the education they need. Okay. Pediatric nursing. It's family-centered care. And this is probably the reason why many nurses don't go into pediatric nursing. It's because you have to work with the family, especially the mother, right? Sometimes. Now, I've been working with children since 1983, I think it is. And it's hard working with parents, but you know, if you're not going to sit down and listen to them, because doctors are so busy and running, who's going to? And I have become such a mentor for so many children and for parents. And even to this day, I haven't seen them in many years. I still get messages on my birthday. I get it on Facebook for Nurses Week still today. And I'm talking 20 years later for some of these children. And actually, one of them, actually, two of them that I'm thinking about, two of them died. And it was the care I delivered while they were there and how I took care of the parent is why I still get that. They still remember that niceness. And that's what I want them to remember. I don't want them to remember a bad experience, a nurse that wasn't caring, because that's not what nursing is. Nursing is that embracing other people and helping them through hard times. Part of nursing in children is they have a fear of, and this is my dissertation, the fear of um, needles. In Miami, they call it no pinche, which means no shot. And it was my dissertation. And I said, okay, how can I research this? So I said, all right, school age children are a great area to research. They're from ages 6 to 12. It's a great spread. And they, at this age, they're pure. They don't lie. They don't exaggerate. For instance, you know, when I say my pain is a 10, that child might say the same pain is a 6 because children don't over exaggerate, right? So asking them all about attitudes and behaviors towards injections. So what I did is I looked at children and I asked them what they were afraid of. And what a lot of it was is they were afraid before, during, and after. Afraid, scared, stressed, nervous. And how was it better? How did I make that better? And actually, it was having the parents hold their child in a comfort position during injections, decrease their anxiety, their fear, and their pain. So, and how did I know that? They didn't cry as much. So, of course, they're going to be upset with a pinch a little bit, but it was gone because they're in mommy's arms already. And the name of my program, and you can look it up on Google it, it's H period G period U period G period Huggies. H period U period G period G period. And it's help us give great injections efficiently and safely. And that's how I would give comfort measures, and I'd reduce the psychological, physiological pain. I help the parents, they're hugging their child, everybody's happy, and it helped the child. So the role of a nurse is all of these things I'm saying. It's that relationship, it's, that family advocacy, and of course, it's teaching, 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 teaching. You know, we know that our job as nurses is to be kept up to date so that we can give them all that up to date information on what's going on with their conditions. So, the leading cause of death among African American boys ages 15 to 19 is, what's the number one?
Firearm homicide.
Firearms is number one. Absolutely. Yes, thank you. And number two would be suicide. Okay. Family, social, cultural, religious. I mean, we all have our own base. We are who we are. You were born in your culture, and your religion is your choice because you're that older now, or it's part of what your family has brought you to be, and that's your religion. Remember, we're all different. So, do I have to believe in my child, my family's religion in order to let them practice their whatever they need to do? Absolutely not. I don't have to believe in their religion. I just have to know what mine is and believe it and give them the opportunity to do whatever they have to do. I mean, some people are prayers and some people are chants, and I've seen all different things in my career, believe it or not. And as long as it doesn't interfere with nursing medical care, please go for it. So, first of all, who is a family? Well, families are all different. It's whatever they say it is. I mean, when my daughter was living with me and she had a baby with me and my husband, that was her family. So now she's happily married. So thank you. And has had another baby, and now that's her family. So then there's a mother and a mother, or there's a father and a father, there's an aunt, there's a grandmother. It doesn't matter who it is, they're all different types. And then, of course, you have your church families, etc. There's so many types. A family is whatever they say it is. And the family is the strength. The family is the one that's going to help you take care of that child in the hospital. If you can get the family involved in the care, you've taught them what to look out and watch for, they can help you prevent problems. As a nurse, you might be given 3, 4, 5 patients. How are you going to keep your eyes on all of them? Who are those family members? Let's teach them this is what you need to do and empower them, make them feel important. As you're assigning these roles, remember there's all different sorts of parents. There are some cultures that only the male, some are only the female, and some, nope, it has to be the nana, the grandma. So again, knowing who is who. Adopted children are different only because we don't know a lot of their upbringing up to this point. So it's just knowing what to deal with now. We know there's all different things that happen to children, and all of these things can affect their medical care, right? Divorce, single parenting. We know that mothers, single parents have to work and the daycare, et cetera, et cetera. So when nurses are, we need to understand not the child, because what I found that I'm not understanding the needs of a child or the needs of a parent. There's ways that you can ask this family, whoever the lead of that family is, if they need help. As a medical professional in hospitals, and you'll see things like homelessness, or you'll see families struggling with food and whatnot. You've got a wealth, a plethora of resources in your hands that you can send to that parent to help them, whether it's social work or get that representative up to talk to them, to help them. There might be things that they don't even know that they can have. Or what I found here in Miami, they were afraid to ask because they were afraid to be deported, because maybe they came over on a work visa or a migrant visa. And that is one of the scares. I used to always be afraid when I used to get a migrant worker child into the emergency room. They notoriously were extremely sick because they were afraid to come any earlier, because they were afraid to be deported. And it was the fear that the kid was so sick that brought them into the hospital. They said, all right, if I go back, fine, but my child needs their care. And then when they find out, no, we don't deport patients here. No, we don't have anything to do with it. We're here to take care of your child. And you could see senses of relief. So a frequent health problem of migrant workers and adolescents would be what? Migrant workers, adolescents. It's actually TB. It's one of the things that we have pretty well wiped off because we have, immunizations all about it, but some countries don't. Okay, genetics. Genetics has to do growth, development, how tall, how short, how fat, how skinny, how many freckles, what color hair, eyes, right? All of this is genetics. So the types of changes that go on is growth, and you grow taller. Development, you're able now to hold your bottle where you couldn't even hold us, you wouldn't even know how to grasp a bottle before. Getting older, being able to get up on your knees and up on your back and standing up and walking. I mean, if you think about what a child does in their first year of life, they can't even hold their head up. And by the end of 1 year, they're walking. So it's interrelated, simultaneous, and ongoing. And you can barely see the differences. I think somebody who comes in every week and sees the kid can see the differences. People up close, they're so close you can't. There's different sort of names that we call patterns of growth of development, directional. I mean, if we're going up, if we're getting taller. Sequential, I lifted my head and then I rolled over and then I creeped and then I crawled and I creeped and I walked. All of these things describe the movement of a child. And remember, every child is different. Many times you're going to hear, if you work in pediatrics, well, my daughter was able to walk and she was 9 months old, and my son, he can't barely even sit up. Is that normal? And the answer is yes, as long as he's almost up to that point. Not every child is going to be walking at 9 months. It doesn't mean that they're smarter or there's going to be a mental problem later on. No, it just means they're a little slower. So metabolism, what am I talking about with metabolism? I sent you all a vital sign sheet, and it's just a guide. It's not an exacting because every guide is going to be different. So don't look at numbers. What I want you to look at is look at a newborn. That heart rate 140 to 160, that's your neonate. That's that first just born. That's metabolism, all right? So at birth, they need that amount of heartbeats to make the body work. By 1 year old, that heart rate is dropping down maybe to 100, 120. So knowing that it will go down and down as you get older. And as adults, it's 60 to 100. That's normal. Another thing is blood pressure. At birth, a normal blood pressure on a normal full-term newborn is 60/40. Really, it looks a little bit, right? Well, by the time we get to be adults, it'll go back to the 120/80 normal. But you can see, just knowing the differences in numbers, you need to understand that. Why? What if you're giving digoxin to a 1-year-old? If I told you the heart rate was 100, can you give it? or should you question it? That's what I want you to think about. What age child? What should they have? What am I giving? What's it going to affect? And what do I need to look out? Or do I have to tell somebody? Okay, good job. Sleep and rest. Well, I mean, I could sleep and rest just as much of an infant if I wanted to, but know that infants sleep more than would a toddler, and it goes, progressively down. But we know sleep and rest is extremely important. And then the one thing you're going to hear me say all term, nutrition, nutrition, nutrition. If you're not giving gas to the gasoline tank, it's not going to run. If you don't give proper nutrition to an infant, to a child, cognition is not going to be where it needs to be. And motor, they're not going to be lifting their head. They're not going to be turning over. They're not going to be doing anything they're supposed to be doing. So if you don't have nutrition proper, everything else, you're going to see it. It's going to be extremely evident. There's all sorts of anybody who's been around kids know, you might have one kid who's great, and then the next kid is the most difficult kid, doesn't sleep well, is colicky, et cetera, et cetera. And that's with temperance, everything. Again, all kids are different. Now, I'm going to basically mention some of the theorists, just to give you an idea. If you do your reading for next week and you're looking at the theorists, Freud. Freud is anything about sex. Oral, anal, phallic, and then genital. Latency, I'll get to that later. It's basically same-sex peers. But again, as you can see, it's related to something sexual. Erickson, he talks about how that baby responds to the people around him. What does an infant do to the people around him? He cries. Why does he cry? Because I want a bottle. My diaper's dirty, right? That's the communication between all ages children. And it goes each stage, infant, toddler, preschooler, school age, okay? Piaget has all of these different things and all of these different names. And all I want you to know is Piaget says that you have to start doing something simple. And then you take that simple thing and you build it into something more. And let me explain it easier. You give a baby a rattle, and finally they do a voluntary, they grasp it. And they go, all right, they got it. Well, all of a sudden they moved their hand and it made a noise. Oh, I like that noise. So they keep rattling it. So every time now they grasp that rattle, nobody taught them, they started shaking it because it happened. Well, then all of a sudden it fell into their mouth. And oh, I like it in my mouth. So now they get it, they shake it, they put it in your mouth. These are little schemas, we call it. They have to do something to be able to do the next bigger type of thing. And it gets to the point where they learn how to even throw bottles on the floor because mommy's going to come get them, etc. So it's starting to think by themselves, and then being able to get to the point of formal operations. Adolescents, they can fight their way out of a paper bag to get anything they want or need. They can figure it out. They can make any story you want. They'll do anything they want to get, because I want to go out Friday night and you told me not. I'm going to make it work. That's because I know how to figure stuff out. That's an adolescent. Cognitive development, it talks about language development. Where does it start? It starts out with that cooing and crying, right? And we know that's the ability to call the environment to them when they need it. They're already starting to think, aren't they? Just by crying, hey, mom, come here. And then there's Kohlberg. What I want you to remember about Kohlberg, it's morals. Right and wrong and a consequence for each. And I think the most important one of those is preschoolers. What do they understand about right and wrong? Reward and punishment, right? They know I do something good, oh, I'm going to get a reward. I do something bad, oh, I'm on timeout or something's going to happen now. Play, very important. Play is what children do from the moment they wake up to the moment they go to sleep. We have different sort of plays, and these plays do different things for them. We can have socioaffective playing together. Sense pleasure is like sand or mud, mashed potatoes smushed up on the high chair. That's play. They are learning texture and smushing with it. Yes, it's a mess, but it's play. They need to have that type of sense pleasure. Skill play, putting a block on top of each other, playing by yourselves. This dramatic or pretend play, we use that a lot with a department called child life. Child life is like a social worker, but it's a person who has learned growth and development, and they actually have learned how to play with children. And with playing with children, they can find out if there was some sort of event that occurred that made them scared about something. Maybe that child goes bonkers when you want to give that child an x-ray, or maybe when you wanted to take a blood pressure. With dramatic or pretend play, they can reenact it and find out where and how that child got upset, and we can correct it. Play is for what? Now, sense. You've already heard that from me. And then into the mouth, Ori, and then moving it around. So that little rattle, okay? I shook it. I heard that there, right? And then in my mouth, and now I felt it in my mouth, and I like it. And moving it around, zoom, zoom, zoom. And it teaches them creativity, intelligence. I can play with it. It's all part of it. And it's a part of socialization. And then they start to know I can do things by them myself. I don't need mommy to shake it and me could go with that little toy, squeaky, whatever. Now I can do it all myself. Types of play are important for you to know. Onlooker play is simple. I'm watching you. And parallel and solitary play is no, I'm all alone, just playing by myself again. There's different ways we can describe them. All those words are all right. Now, these three, you need to know the differences. Parallel play. There's a parallel line, one next to each other. There's a child in this line playing and a child in this line playing, and they're toddlers. They don't share. They don't like to give anything to anybody, and they want to be on their own. Me do, I do, mine. Parallel play, no sharing, playing next to each other, no sharing. These are toddlers. Associative play is now they can all play together with all the same toys, but there's no goal. They don't win a game like checkers. They don't build a castle. They don't finish building a race car set. No, they just playing. Cooperative play now is school age. School age children, there is a goal. Somebody wins. The castle is made. The car set is finished. You won the game of checkers. Those three plays you must know. Why do we do this tummy time and these toys type of things? Well, as infants, they're born with these bodies that can't even lift their head, right? They don't have any muscle control. So putting them on their tummies, number one, it helps with that little flat spot in the back of their head. That's the first thing. And number two, they start squishing and pushing and pulling, and they're using muscles trying to get to that toy. And I'm going to take this one step further. Many times we will take a toy and hide it a little bit above something. So they have to work a little bit to get to it. So it's hidden, but that infant still knows it's there. That is called object permanence. Even though they can't see it, they still know it's there, and they're still trying to push, pull, or roll, or manipulate themselves to get there. Now, developmental assessments. Why do we need to know developmental steps? Why do we need to know when they roll over, when they sit up, when they walk? Why do we have to know these things? Well, this can really look at what's going on cognitively. Are you getting enough nutrition would be the first thing they'd look at if they're not up to that level. Or maybe there's some sort of syndrome that we haven't seen yet. And if we're looking at children that are delayed, whether in motor or skills or speech skills, this can By doing these frequent developmental assessments, we can identify delays and we can institute early intervention. And that's the whole thing, is to institute early intervention and catch them up. Have you ever had a child who was put in speech therapy because they could barely talk? They're age 2, they can barely talk. Put them in speech therapy. 6 months later, you cannot shut the child up and talking. And that's usually what happens. They catch up quick, and that's the beauty of children. So the quicker we institute it, the quicker they start yapping more, right? Some of the things that we might see, with delays, cognitive delays could just be, they just have a delay and they just need a little extra help to catch up. Or it could be a severe cognitive delay and it could be a syndrome, as in Downs or Prader-Willi or Turner. Those are 3 great pediatric assessments right there, if anybody wanted one of those. If they have a syndrome, their assessment's not going to be the same as a normal child. So we need to understand that, and we need to take that into account if we're assessing the child. So communication, physical assessment, child, family. Well, I put in here all about the medical record. Well, we know the medical record has to be protected. It's all that HIPAA stuff going on. Yes. With children, this is the one thing you have to be concerned about. 18-year-old child comes to the doctor's office, to the ER, urgent care, and they're complaining of whatever, and can they go into there with their own signature? If they're alert, oriented, cognitively normal child, they can sign for their own and have to sign for their own medical care. Also, if the parents are with them, as a nurse, you have to ask the parent, can I speak freely in front of you? You have to ask the child if you can speak in front of the parent. They're 18 years old. They're in charge of their medical care. And that can be tricky. So it's better to ask than to be sorry with that one. Communicating with families, this can be overwhelming at times. Again, you want them to talk. You want them to tell you what's going on, but you need to direct the focus back to this visit. You have some parents who will give you a dissertation from birth and they're 8 or 9 years old, and you don't need that much. You need to know what's going on this visit. Again, listening, okay? Listening, and that knowing cultural awareness, as in, can I look at you in your eyes, and do I touch your shoulder when you're telling me all of this stuff you've been through to get your child here and how sick they've been? There's some people, some cultures you don't touch, some you don't stare in their eyes. And again, if you don't know, or you see them pull back when you're trying to touch them, say, oh, I'm sorry, I didn't mean, if that bothered you, if you want me to touch you, I won't. Or is that okay if I, is better than. I've found parents are really appreciative when you ask, that you don't just ignore, but you ask what they want. It makes them feel important, that you really do care, okay? And again, if this patient family is of a language you don't understand, do not use the older teenage brother. You must use an interpreter, because any family member could put those interpreting into their words, not into exactly what the parent said. So use an interpreter or use one of those phones that we can get. Remember, when communicating with young children, you must get on their developmental level first, which means getting down below them. I am not a little girl. I'm 5'8". I'm 200 something pounds. I mean, I come in there and they're going to think, oh boy. No, I'm going to sit below them. I'm probably going to have a little sticker or something in my hand to crack the ice, especially on those little toddler preschoolers. They're scared of me, right? And I'm now on their level. I have now made it fun. We're playing a game. I'm below them. I am non-threatening, okay? And you can do that with any age child. As an adolescent, know that if you need to, You can have parents leave the room and talk to the adolescent alone if you need to ask some personal questions. And you don't have to tell the parents what the adolescent said unless it will hurt them or others, okay? So it is one of those nurse patient confidentialities. So getting a history. Well, we know that performing a health history, we need to know who's going to say. Now, there are cultures that grandma always wants to talk first. If that's the one who's been in charge of the care, then we'll speak to grandma. If it's mom, we'll speak with mom. Again, get the informant, all right? What's going on now? Give me the symptoms, let me know immunizations, very important. And that is very important when we're doing like patient placements, when we're trying to get them into the right where they need to go, right? If their room is with another child that has an upper respiratory, you'd want to make sure they're both immunized, because what if one had pertussis? That's something that if the other one was immunized, we could spread it. So that's important. Of course, allergies are always important. And of course, any medications, ibuprofen, acetaminophen, etc., and any previous histories. Also, I like to get their dietary history. On admission to hospitals, etc., it's a really good time to look at, especially if they're on specific dietary restrictions. Like, let's say they're only vegetarian. This is a great time to get in that dietitian. They can look at their diet. Did they get enough protein in their diet, etc.? And then the other one is habits. Do they have a special blankie? I know when my grandson was younger, you couldn't bring him anywhere unless he had a special blankie and he had his little beanie baby. It was a giraffe. If you didn't go anywhere with it, he had those two things, he was a happy person. So again, knowing those things for a nurse sometimes is important if parents have to step out. Again, that sexual history, as I said, you can have parents step out of the room if you need to. And it's always nice to see what's that structure of the family. You need to know, because you need to know, who am I directing all of this teaching to? Some of the things that we like to look at is school adjustment. I ask young kids, so what's your favorite subject? Or who's the name of your teacher? Or what grade did you get? And if they'll say a C, I said, okay, you passed, it's good. Or, always making them feel good. I also like to look at how the parent and the child are acting together. I see sometimes you put them in a room, a child and a parent. The parent is on a phone, the child's on top of a stretcher, into these little eye to the ear, little things you put in your ears, and tongue depressors and things thrown all over, and the mother didn't say a thing. Now, does that make me feel that that parent is really watching the child? So we have to readjust that parent. Hey, could you please watch your child, and these things could be hurting them, et cetera, et cetera. So again, as I said, we looked at the nutrition. As I said, we can also monitor that and have dietitian. Now, do an assessment on a child. It has nothing to do that you would do with an adult. So adults, we do head to toe. Children, no. If they are asleep, a young child is asleep or very calmly sitting on a parent, this is when you're going to listen to breath sounds and heart sounds. And then you get all the other stuff in when you can. Okay, very important. You cannot go head to toe. It's not going to happen on their child. Another way we can prepare them is, I love doing play and play. I'm going to listen to my heart. They listen to their heart. I'm going to push the button and do my blood pressure. They're going to push their button to do their blood pressure. All of these things help that child sit, and you can get all the information you need because you put a little bit of play in there. Another thing is, if something you're going to do is going to be painful, you need to tell the child it's going to hurt. And you're like, but why? Well, if you don't tell them it's going to hurt a little bit, but you'll do everything to make it as little as possible, and then You don't tell them that and it hurts, they're not going to believe you anymore. Children don't forget. So again, let them know what's going on, what they're going to feel. Just basically teaching them what's going to happen. So which approach would be best to use to ensure a positive response from a toddler? Those ages 1 to 3, kid.
Would it be A?
Hey,
Yep, you gotta get down on their level. I like to get even a little bit lower, give them a little power, right? And then just start gently talking to them. And then depending on the age, depending on what you could do, make it a game, make it fun, and make you not as threatening as what you really are. What does a child see every time they go to a doctor's office, ER, urgent care with a nurse? We're always sticking them and hurting them somehow, aren't we? So we got to make this more fun and easier on them. That's your job. What do we measure? Everything, right? Not everything all the time, but see, these are things we do. Now, we do have growth charts. I know parents look at, oh, we're at the 96th percentile. We know we measure height, weight, length. Head circumference is mostly on your newborns, making sure that they don't get any increase of swelling in their brain, usually due to water hydrocephalus, right? Temperature is done every time, and we do apical pulses mostly on children 5 years old and less because radial brachial pulses just are not, it's easy to do on these kids. Blood pressure cuffs, you know that there's all different types. I'm going to show you what they look like in a second. One of the things with kids is there's something we call sick appearing and well appearing. You can look a kid, seeing them in their face, you know which one is sick. They don't look good. You can tell their color. I mean, that girl in the upper picture is smiling, looking at her. She looks happy, right? I mean, the kid on the bottom picture, well, they're retracting. I know they're not feeling well, but you can see just by looking. Another thing we look at is lymph nodes. And just to let you know, lymph nodes you should not feel unless they're sick. Because lymph nodes are that white blood cells. That's that infection control center, right? If they're swollen, it's trying to do something. We look in their ears, their nose, their throat, their mouth, their chest. Again, a lot of it's just looking and then it's listening when we can, right? Looking at the abdomen. Is it round? Is it large? Is it soft? First, we just look. We can tell sometimes is it very distended, and then do the auscultation and palpitation. And we do check genitalia. There is ambiguous genitalia. There's also something that I didn't know until I started working in the ER is sometimes females, they tend to get their labia tend to fuse together. So it's you see a labia, but it's not open. And usually that's the child I have to do a urinary catheter on. And you can barely see in there, right? And it's very easy to take care of. They actually put a hormone cream on it. They have to go to the endocrinologist and they put the cream on it, and it just by itself will separate it. But again, genitalia, make sure you document it. And then why do we check an anus? At birth, you're taught, take a rectal temp. You were taught that in OB. And you were told that's for an accurate temperature, right? It's also to make sure they have an anus. Do you know some children are born with an imperforated anus, which means nothing? That means where's all the bodily fluids going to? Nowhere. So we need to do a intervention pretty quickly, don't we? So just to let you know, it happens. We're going to look at their back, making sure that there's nothing puckering out the bottom of their spinal cords. We'll go into those things later on in this term about that. And then, of course, that neurological assessment. Older kids love to check the knees and bang their own knees and watch them bang. And, again, making it fun. That's what pediatrics is. I used to love to go to work because I went to work every day to play. And that's what I did. This is where you do the head circumference, chest, and abdominal circumference. Remember, at birth, the head is bigger than the chest. By 1 year old, the chest and the head are about the same, and the chest is getting bigger, just to let you know. Abdominal circumference is what we check, especially in your infants or anyone that has anything to do with something with the abdominal cavity and worry about feeding and swelling. We'll be doing abdominal circumferences. We also check their height. Are they growing the way that they should? That little piece of wood over their head, kids get scared about. They don't like it. They think it's going to come down and bop them hard. So what do? I say, okay, watch me. Let me show you me do it. And I take and go pop, pop, pop. Oh, it just touches. That's good. And on the side is always the number of what your number is. Says, oh, I'm a number 7. What number are you? So we put it down. Say, okay, hold it. Pop it down. Did it hit your head? Now I made it a game. But I have gotten an accurate height, which in some cases is extremely important, okay? Again, make it a game. Blood pressure cuffs, you can do them almost anywhere on a child, just like adults. But for those toddlers and those preschoolers, I absolutely love number D because I can hold the leg, it doesn't hurt as much, and I can distract up here, and I can get an accurate blood pressure. And it is an accurate blood pressure. Now, if I needed a cardiac child for extremity, yes, I will do what I need to do. But if I just need a blood pressure because I want to quick find out if it's okay, that's what I would do. And then the last chapter of today. Pain management. Now, I think pain is one of the things I have watched not being addressed in children for a long, long, long time. I started working in pediatrics in 1983 at a county hospital. And busy, busy, busy place. And I remember this one little baby had something called Pierre-Robin syndrome. And I'll never forget this little girl. And Pierre-Robin, the tongue tends to fall in the back of their throat. They got tiny little jaws. It's a bunch of other stuff. In fact, that's another good diagnosis for you all. And the surgeon came in because the tongue kept falling to the back. So they needed to stitch the tongue to the lip to keep it from falling back and occluding the airway. This surgeon came in, and before I could get or grab anybody, took a suture out and sutured that tongue and that lip with no sedation. Of course, you know what that baby did. They cried, and I'll never forget her. So always remember, infants do have pain too. And you think they don't remember, you'll be surprised. They actually remember pain. So children continue to suffer from inadequately treated pain because you're not assessing frequently enough, you're not giving enough, or you're waiting too long. Okay. And did you see that it worked? I mean, just because you give pain medicine doesn't mean it worked. Not all pain medicine works on everybody. There might be a better choice. Some hospitals have evaluations. I think the one I worked at, one of the things that they called it was PI, the pain intervention and evaluation. So you found pain, what did you do? Intervention, and then you evaluated it. Did it work? And that's the most important part after you medicate. Now, an infant or a nonverbal child, how do you know if they are in pain? Well, if you look at that picture down there, I think you can see an infant who doesn't look like they feel really well. What do you see? I see facial grimacing. I see crying. I see a child uncomfortable. So the scale that we use from 0 up to age 3 is a FLAC scale. It's also used for nonverbal children, and that could be an 18-year-old cerebral palsy child. Okay, nonverbal. And what we look at is, what does their face look like? And there's numbers 1, 0, 1, and 2. So that baby would be a 2. That is facial expression grimacing, isn't it? Right? Leg movement, I don't know what it is. So that's your LFLA activity. Some children, their legs are moving and they're just, and they're miserable. And some children are so still and they don't even move. because they hurt so bad, okay? And then you have the crying, and they're inconsolable. That would be the FLAC. Again, 0 up to age 3 and nonverbal. That was a HESI question. FACES is the scale that we use for ages 3. We can use it all the way up till adults, but they say 3 up to when we can use numeric, which is at age 8. Now, FACES is a scale that the child points to the face. If you look at this, children, it breaks my heart because I know that there's some kids, they are hurting so bad. And when they look at that scale, I don't think a child has ever put a 10 to me. I think that 8 was the highest I've ever seen them point to. And I've seen them in really bad pain. Very, very honest. I put another one down here. Visual is one that we have. Faces pain scale. But FACES, Wong-Baker FACES is the one that we use. Again, 0 to 3 FLAC, 3 and up is FACES, and it's looking at the faces on the scale. At age 8, we can use numeric, just like we do for adults. 0 is no pain, 10 is the worst pain in the world. How much pain do you have, okay? And then again, there's that nonverbal FLAC scale. So again, it shows you there, it shows you the 0, 1, 2 and what you would be seeing and etc. And it does really, really evaluate it. You know, for years we didn't evaluate pain. And then the Joint Commission came in and said, hey, we're not evaluating pain here good enough. So it started all over the country internationally. So we know pain, there's all type. We have the chronic, that could be the rheumatoid arthritis, that could be sickle cell, right? Reoccurrent is a sickle cell. Persistent, I mean, there's all types. There's acute pain, appendicitis, etc. We know if you have a child, and there are children who live in chronic pain. It's not just old people that do this. There are children that live in this chronic pain, and it affects every component of their life, physical, emotional, social, and at school. Many of these hospitals have all different sort of pain scales. Now, I've given you a couple, I've shown you them. It doesn't mean those are the ones that will be used in your facility. I think FLAC and FACES are, and numeric are the 3 that are globally used. The other ones are some of them, but just to let you know, there are different scales in there at your facility. Use the appropriate one. Now, pain management. So we think of pain. Now we've given the pain medicine. Now that's enough, right? No. If you give the pain medicine and then you distract them, let's say you put on a video, let's say you gave them something to color, gave them a puzzle, I always had, as I said, stickers in my pocket. I always had princess stickers, always had Batman, Spider-Man, always, because this is something that, oh, look at that. Oh, I like that one. And then you start talking about that princess, or you start talking about that superhero, and you forgot about you were in pain. You gave it already, but now all of a sudden the kid is quiet and now falls asleep because now they're comfortable. Okay, that's how distractions can be used. There's other things we can do in little tiny little infants, you know, ages 1 and under. This is that swaddling. Sometimes they like to be nice and snug and tight, swaddling them in their blanket. That sometimes helps with the pain. Probably the best thing to couple with pain management is non-nutritive sucking or a pacifier. My grandson had his circumcision at 1 month old in the doctor's office with a pacifier with sugar water on it. They didn't let me go back. I wanted to, they didn't. And I could hear him cry, but it's because they put him down and had to tie him in this thing so his hands and feet wouldn't move, okay? They did the circumcision. When it was done, they let him up. He never cried again. So in my research, part of it is, pain control. I researched this pacifier. And what I found was a research article by Harvard neurophysiologists, I think they were. And they looked at morphine and a pacifier with sugar water for a circumcision. And do you know which one they found worked best? They both work the same, morphine or a pacifier. So what's safer? Pacifier. So that's where that came in. So that's why we encourage pacifiers today. I mean, I've seen pacifiers, you like them, you don't like them. There's been all over the place, but I think we've come to the point where pacifiers are good because how do children calm themselves? With their mouth. And then the last thing is kangaroo care. This mother has this little, you can barely see the top of his head, but little tiny little premature baby, less than 1,000 grams. Now, these infants in warmers or even in their isolates, they're just movie. They're fussy, and their heart rates are up and they're burning calories like crazy, right? Mommy comes, puts them even intubated, all sorts of central lines and everything, put them on top of that mother's chest. You will watch the heart rate come down, the blood pressure come down, and that baby goes to sleep. And it's the most wonderful thing to see. Just kangaroo care can be all the pain management that poor little guy needed. We don't always have to give things like morphine. And you're saying morphine? Morphine is the oldest, safest narcotic we can use for children or anybody. We've been around so long, we've researched it like crazy. But we don't just give extra doses of morphine. We can also augment that with acetaminophen or an NSAID, and it works well together. Just like you would alternate Tylenol and Motrin for fever, same thing with pain. Morphine, Tylenol, morphine, ibuprofen, it works really, really well. Another thing we can do is a PCA pump, patient-controlled analgesia. Can you see a child with one of those pumps giving themselves their own pain medicine? And then you're going to say, gee, that could be scary because they like to play with the pumps, right? Well, you don't give them just to anybody. You would have to have an older child. It could be an 8 or 9-year-old, absolutely. And they need to be alert and oriented enough to be able to work it. And it can be used effectively. Now, these pumps have lockouts. There's certain amounts they can give, and you can't give an extra dose until a certain amount of time lockout. And they only can give a certain amount in 4 hours or whatever it is. It's really hard to overdose if they're using that PCA pump, and it gives that child control. What if they had major surgery, and they're in severe pain? This is a great alternative for that patient to be in control. Another thing we use is things called EMLA, numbing creams, Let cream, and it's used to help prevent pain. I've used that little glob underneath that plastic thing is a Tegaderm, and that's EMLA. It's a numbing cream. This little girl's going to get her blood drawn, and she knows with that cream there, it's not going to hurt, so she's happy. We use that for spinal taps. We can use that to put in central lines, in the groins. We can use it anywhere where we need to numb something. It is a great tool to use. And these kids now, especially what if they are a chronic kid, always in, let's say a sickle cell child, always coming in, always getting lab drawn. And sometimes it's hard to see veins on these children. This is a great thing. They're not going to feel all those stick with pains. Where do kids get pain? Well, anywhere, right? We have the teething. We also, immunizations, vaccinations. One of the biggest complaints of parents is that first couple sets of immunizations, there's like 4 of them, right? At 2 months, 4 months, 6 months. And it's 4 immunizations. That's a lot to give this child, and parents are concerned about the pain. we can give those numbing creams there to decrease the amount of pain as they get it. We also can teach them how to take their knees and to bicycle them, to move their thighs and to move that immunization in the muscles so it's not going to be so caustic. And we could put hot packs, cold packs, whatever they like on it, so to use it. Of course, we can use it with circumcisions. I mentioned that. Again, that pacifier is great. Again, knowing that all pain are all different. They all need different sort of types of therapies. And the kid's going to tell you what's going to work the best. So, which of the following is an important factor for consideration in understanding the pain experience in children?
B.
Absolutely. Good job. Yes. They're not going to tell you why. Kids don't like medicine. They don't like it by mouth, and they don't like a needle for sure. There's also the cultural component. It could be that little boy whose daddy's saying, "Oh, suck it up. You're a big boy. You don't need something." And I've seen that too. So, absolutely, they do not say that they're in pain. So, we do have a cahoots. I've got something that we need to discuss. We can take a break for 30 minutes and come back and do our cahoots, or we can do a cahoots and come back and we'll leave early. What would you like to do? We can either go straight through and get it done. We will be done early. We'll be about 45 minutes early, 40 minutes early.
I opt for doing the Kahoot.
Me too.
Kahoot.
One,
Let's
two,
just
three,
do
four,
that.
5, 6, 7, 8. Okay.
Mm-hmm.
It's whatever you all want. And I'll tell you, this week I was able to get a lot more things in and quicker. You might hit another week where I run a little bit longer. So basically, I'm giving your time back before you're getting it. Okay?
Okay.
But I know the first week you guys are there. You're ready. It's Friday, right? I understand. Who wants to win today?
I do.
Good job. Well, I think you should then.
I think I should.
Let's have a fight to the finish. I'm teasing. Nobody fighting. I'm
Nah.
not a fighter. I'm a lover. No fighting. Remember next week, this week, all you have is that discussion question due. Again, be careful with submitting into Canvas. 2 times every week, you must have something in there that you've done.
Okay, 1, 8, 1, 3, 6.
You can do that code and go right there, or you can go to kahoot.it and put in the PIN number, whatever you like.
Why am I not seeing this?
Heard a lot of bing, bing, bing on my messages, but somebody needed me quickly. Anybody else coming?
I can't get in.
Hold on. You got it?
Nope. That's okay.
Is everybody else who wants to be here here? You can just sit back and you can listen too, but that means you can't win.
That's okay.
All right, here we go. Week 1. The leading cause of death from unintentional injuries in children is. So when you look at this question, you've got to say which one of these can hit any age group. Remember, we're talking infants, toddlers, preschoolers, and school age. And one that fits all of them, yes, motor vehicles, whether they're in it or rolled over on it.
Professor, what was the code again?
1 second. Which statement is most descriptive of pediatric family-centered care? 818130.
Thank you.
You're welcome. Family-centered care. Well, we know in children, what's the one thing they know? They only know their family, right? And it's only as they get out into the public in daycare and school and other families and relating with other children that they know more than that. The only constant is what they know, and that's their family. The major cause of death for children older than 1 year old is what? Well, think about toddlers. What are they into? How about anything and everything all at once? And it is unintentional injuries. You know, things happen and we don't, it's not because we wanted it to happen to them. I mean, with toddlers, I have seen things like climbing on the second story balcony, climbing up and over and falling to the ground. I've seen that. I've seen climbing up dressers to try to get to the TV. TV's fallen over on them. I mean, these are the two big ones I can go. I could go on and on. Toddlers get into everything, and it's totally unintentional. I mean, this is why all about those straps on those dressers became more and more and more. It's because we were seeing more children being dressers over on them. The nurse caring for the child in pain understands that distraction. What is distraction?
Green?
You're funny. Yes. Remember, I can sit and give a sticker to an infant and they don't care what that is, right? If I take a little squeezy toy and shaky, well, they'd understand that. So remember, you can't give them something they can't understand because it's going to do nothing to distract them. In what type of play are children engaged in similar or identical activity without organization or mutual goal?
Associate. Blue.
Parallel.
Yay.
Without a goal is associative. Then I'll ask you, what age child is that? Preschoolers. Preschoolers like to play together, right?
Yeah.
Who doesn't like to play together? Toddlers, that's parallel. They parallel next to each other. And then school age children, they like to cooperate with each other. And they want to make something. And that's cooperative, okay? Those 3 ones, you need to know the differences. Which statement best describes the process of critical thinking? I remember walking in the first day of orientation for some nursing students, and the dean was talking about having the ability to critical think by the end of being in nursing school. And then I thought, you critical think every day. I mean, you all have to figure out what's for dinner tonight, right? Where are you going? Who are you going to be with? What are you going to have? Isn't that critical thinking?
Yes.
As simple as that. in nursing is I see a child and I look at them. What do they need? They look like they're in pain. Let me get them something for pain. And did it work? It's as simple as that. Critical thinking. It is not anything mind-boggling. It's simple. Just pick it apart. What do you need to know? What do I need to do? Did it work? What is possibly the single most important influence on growth at all ages of development? Nutrition, 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 nutrition. If you're not feeding the gasoline tank, it's not going to get up and go. In fact, as I said, when you have a child who is delayed, especially those young infant between ages of 0 to 1, these children, if they're not rolling over, they're not sitting up, they're not doing what they're supposed to do, the first thing we look at is nutrition, okay? Are they getting proper nutrition? And next week we'll go into what that means. Which function of play is a major component of play at all ages? What's play all about? What does it do? I grabbed the rattle, I shook it, and now I'm moving it all over the place.
Green. I can't get in.
It's okay, my dear, it's okay. And yes, it is. It's sensory and motor activity. Remember, it's all about that touch, the mouth, because that's everything explored there, and then moving it. This is how that creativity, and this is how they start learning, that intellect starts there. How do you apply nystatin to an infant with thrush? This is one of those things, infants, they get that white, that ungle, it's another word, and it's, you want to scrape it off with a tongue depressor. And this is a difference that you would do different than an adult. Children have different procedures than adults. In an infant, we're going to take a cotton swab, a Q-tip, put it in the medicine, and we're going to paint on that white spot. And on an adult, we're going to swish and swallow, right? Or squirt it in. But how would an infant swish and swallow? They can't. So again, showing you differences, adults, children, differences. 3 children playing a board game would be an example of. You're playing checkers. What is it? And that is cooperative play. Remember, a board game like checkers, there is a goal. It's 3 children. It's 2 or more playing a game with a goal. A goal on a board game is checkers, I won. Cooperative play. And what age child is that? School age. The head to tail direction of growth is referred to as, take the word, pick it apart. What's another word for head?
Cepho.
There you go. Sometimes it's looking at the word and making sense of it. I want to give you another one that's very similar to cephalocaudal. Cephalic head, you know that had to be the answer. How about you have a child that you're looking for strep in their blood, and you look at an ASO titer. Anti-streptolysin titer, that strep is in there, we know then that one has to be it also. So again, I'm just telling you, sometimes it's looking at the word, making sense of the word, you can get answers here. What is the single most important factor to consider when communicating with children? And it's that child's developmental level. You know, you walk into a child, as I said, with a sticker on an infant, and they're going to look at you and say, I don't know, but do a little squeaky toy, and now you've distracted them and you've started that communication and you can talk. Again, very, very important. We are a threat. A nurse to a child, we're a threat. All we do is hurt them, it seems, to them. Let's make it more of a game. What 2-year-old child pain scale assessment tool should a nurse use? 2 years old. what scale would be appropriate?
Basic.
Faces.
Red.
Think again.
Oucher.
I didn't mention that one, so it can't be. If you ever see a word, I've never mentioned it,
I was
don't
like,
ever pick it. It's never the answer. I see that on exams all the time. There's this crazy word that's been put there as an answer, and several students will pick it just because it's this fancy word. Don't fall into that rabbit hole, please.
okay.
So FLAC is faces, legs, activity, consolability, and crying, right? That is that young kids who can't express what they want. That's FLAC, 0 to 3, and nonverbal. 3-year-old and up is faces. That is, they can point to it. They're alert enough to point to a picture. Below that, nonverbal, it's the FLAC scale. Very important. There's many questions that will come up regarding, you have a child with what would you use with this condition? And they're just looking for a pain scale, but they're putting all this distractor information in there with you, right? So
Yeah.
again, it's just knowing 0 to 3 and 3 and up, and you'll be okay. At 6 months, an infant's birth weight should do what? Now, the reason why we look at weight is to look at nutrition. Are they getting the proper nutrition? How do we figure that out? Oh, if they're
Weight.
gaining height and weight, they're
Mhm.
doing good. So a baby who is born at 7 pounds at 6 months should be 14 pounds. By 1 year, they should be 21 pounds or triple it. Do you know they do not quadruple till they're 2.5 years old? Do you see how much his growth is done in the first year of life? It is amazing. The first expected fine motor developmental milestone for an infant begins with. So we're trying to assess a child. Developmental milestones are fine fingers, fine motor or finger. What do we do with our fingers? So the first thing is just this reflex that we do. It's like you put your hand or rattle in there. They just try to grasp it and they don't know why. It just happens.
Mhm.
And that's number one. And then it becomes voluntary. Oh, yeah, I like that rattle. Let me grab it. And then I do all the other stuff with it. And then we put them in a high chair, it seems. That's about that 8 months old where they can sit unsupported by themselves, all right? Sit them in a high chair and you put those little puffs or Cheerios on the table, right? They take and they smush their hands like that. And they call that a pincer grasp, but this is crude at first because it sort of smooshes. And then all of a sudden they take one, take another one, and it becomes that fine pincer grasp. As we go through your reading for next week, this fine motor, gross motor, very important. You look at what is the evolution of them. I'll go over it and over and over again, but it can be confusing. An 8-month-old infant should be expected to perform which fine motor skill? I think I sort of said it. 8 months, we put him in a high chair. What should we be able to do? So by 8 months, they should grasp that rattle and they have that crude pincer. Okay. As they get more, it'll be that fine pincer grasp. And then it goes into putting blocks in or out of container. All right. And that's 11 months. At 12 months, blocks of 2. Again, it's in the reading. I'm going to go it again. Next week, we'll say it again. The natural physical developmental sequence that most children follow. What do they do first? What do they do second? And this is all gross motor skills. So the first thing they do is their head, okay? And I'll go into it more in detail. I'll go briefly. Heads lift up by 3 months. They roll from their belly to their back, 5 months, back to belly, 6 months. Then they're up on their knees at 7 months. They are walking, sitting unsupported at 8 months. Then they are cruising by 9 months and attempting to walk by 12 months, 1 year. That's about the sequence of events. Which behavior indicates that an infant has developed object permanence? Remember, that's that tummy time thing that I was talking about. So tummy time is the best time to exercise these children. It's also a time, we'll talk more about it next week, about how parents are concerned about the flat heads because of putting them back to sleep all the time. And their heads can get flat. So we put them on tummy time to round out their heads. We also want them to move so they get their muscles strong. And we put a toy in there and hide it. And then they go looking for it. And it makes them move and gets them stronger and stronger. In general, an infant should triple their birth weight at what months of age? And they should triple it at 12 months, double it at 6 months, quadruple it at 2.5 years old. Perform a head to toe assessment on a toddler, most important to consider before beginning the examination.
Okay. Red.
So the thing is, we're focused on the child. Now, sometimes the parents can be there, sometimes they can't. So
Okay.
when you have the child alone, what's the most important thing to consider is that you need to get on their level. Again, we're making it a game, we're making it fun, we're gaining that trust, and that's how we do it with children. According to Piaget, toddlers are in the blank developmental stage. Remember, this is the thinking. We took the rattle and we put it in the mouth, and we took that in the mouth and we shook it and it made noise. And we're learning all of these things. We built upon just getting the rattle in the first place, right?
Yep.
And these are all types of sensory or motor development. Piaget, the thinking, and it starts with that basic, I grasped it. Okay, now I can do it by myself. Now I can rattle it. Now it goes in my mouth. And it's building on those small things and becoming smarter and smarter. Which intervention helps a hospitalized toddler feel a sense of control? So, sense of control. Toddlers like routine. They like to do the same thing, same time, every day, and they know what's expected because they don't like to think and they don't like to be disrupted. If you give the bath at night, continue at night. If you give it in the morning, give it in the morning. Foods, if we can, try to keep the same sort of foods that they like. Again, this gives them a feeling of control. They don't feel like scared because they're comforted because they know what's coming next. All children reach developmental milestones at the same age. All kids walk at 12 months old. Absolutely not. You have some children that are walking at 9 months. Honestly, my children, they never walked. At 15 months, they ran. Immunizations for a 4-month-old infant. Which action should the nurse take to provide atraumatic care for this infant? Infant atraumatic care, what have you learned is the best thing? Don't overthink it. And that's that good old pacifier. Good job. Remember, aspirin is never given routinely to any child, okay, at all. There is a high incidence of Ray's syndrome. It has to do with a viral infection and then taking aspirin. There's one condition that we're going to give aspirin to, and that's you'll learn that on week 5, all right? So it would never be that. And Z-Track is only used when we're doing things like an iron injection or caustic or burning medicine. So that would never be it. And would you have the parents leave? You know, that little child wants them to hug that little kid while getting an injection. No, I want that parent there if they're there, for sure. Which of the following immunizations is administered to a newborn? You know, during this course, we have, you're going to see a double page of immunizations for children. And you're going to say, oh boy, how can I remember all of these things? So what I'll tell you is the first immunization is hepatitis B, usually given at the hospital prior to discharge. But there are times, it's an insurance thing usually, they don't give it till their first visit to the doctor, usually 2 weeks later. Now, some of these immunizations here, there's no untoward things. When we get to things, would you have to know what they are? Well, MMR is not till 12 months with the polio, and DTaP would be one of the first ones we give. Knowing things like varicella is a live vaccine. You can't give it, you know, to any immunocompromised child. And remember, immunocompromised also means on steroids. They're on a steroid therapy for like croup. You couldn't give them an immunization at that time. These are the sort of things about immunizations you're going to be taught about, not necessarily the dates of every one. So don't worry about the dates of every immunization. What's first? What's the first group? What's the ones that we need to be concerned about as we get older and maybe special treatment while giving those? The normal heart rate for an infant. And that normal rate for an infant is about 140 to 160. And again, as the child gets older, what happens to that heart rate? It starts coming progressively lower and lower and lower. And why do you need to know things like heart rate, blood pressures for every age child? And when you don't know, ask, look it up. It's not a problem. You don't have to know all of the things. Know where your resources are. But if I'm going to be giving a medicine that can affect a heart rate or a blood pressure, I'm going to have to know what the normals are before I give it. What is the preferred site to give an injection to an infant? And if you look at that picture, how many wrong things can you see there? Somebody should be holding that little child's hands, don't you think? And it is the vastus lateralis. And I always get somebody with a deltoid. That's not till they're later on. They can't handle it in their deltoid muscle yet. The death of an infant under 1 year old with no known cause is what? And it's called sudden infant death syndrome. Sudden infant death syndrome, there are things that we look for. Actually, a breastfed baby has decreased incidence of SIDS death than a bottle fed. Males are at higher incident than females. Smoke is a big thing with it. And then, of course, this is the reason why many hospitals do these research on their newborn ICU and SIDS death and putting them back to sleep. Hospital where I worked at, they called it Back to Sleep. That was the name of the program. It's been ongoing for 20 years. They watch it and monitor it and see the differences. And they've actually, positioning has changed over the 20 years. So now it's only on their back. And again, this is when parents get upset about the flat heads. Do tummy time. It'll nice and it will round out and it'll be okay. The Vietnamese mother of a child avoids eye contact with a nurse, considering cultural differences. Why? And then I'll say, if you don't know, I would ask the parent. Say, I'm interested in your culture. Can you tell me? Is it something that I did that bothered you? I mean, we could think different things and it's okay. And as again, I'll tell you, the parents really appreciate you asking. And it's respect. A child from Mexico is hospitalized for a serious illness, and the father says the child's being punished by God. Why did he say that? Again, this is another health belief, and it's what they believe. And you're going to see as we get into preschoolers and school agers and their belief about being hurt, these young kids also believe that, I hit my sister yesterday. That's why I fell down and I broke my arm today. They believe sort of the same things, that they did something wrong. They're being punished by God. So it's not even just necessarily cultural. It's actually your young kids also believe the same thing. Which term refers to times in an individual's life when he or she is more susceptible to positive or negative influences. This is one of those terms. And it's called the sensitive period. What is the characteristic of the pre-operational stage of cognitive development? Okay, this is ages 2 to 7, and this is Piaget. What does children of those age can understand? Can they figure it out? Or do they have to see it before they can figure it out? And the thing is, they have to see it before they can figure it out. Let me explain what concrete means. You can see it, you can touch it, you can feel it, you can smell it. It's concrete, which means they have seen it or done it before and they can do it again. Now, this is the younger kids. As they get to be adolescents, they can do it. It's abstract. They can think and they can abstract their way out of paper bags, as I said. They want something, they'll make sure they get it done because they know what to do or say to do that. But younger kids, ages 2 to 7, they have to be able to see it. Somebody else has done it before, or they've seen it before, and then they'll do it. And last question. According to Kohlberg, children develop moral reasoning. What is a preschooler stage of moral development? What did I tell you about morals? What is morals? So actions are determined as good or bad in terms of their consequences or reward and punishment. And that's all about preschoolers and what they believe in and the way that they act in their moralities. Let's see who won today. Number 3, Ellie. Good job, Ellie. Good job. Number 2,
J.
B. Is that me, B? No. 1. Alexa. Good job, Alexa. In number 4, tie in, you see. All right. So today we did a lot. We got done with it pretty quick. It was not too bad. Know that some days it won't be as quick, but I'm going to try to get you out of here on time, to give your time back to you when you deserve it. Remember that this week's discussion question also has a nutrition part of it. It's not just who you are. Make sure you get that in. And anybody needs any questions, comments, concerns about anything, please send me a message. And if you have any of the, if you have an accommodation, let me know so that I can help, set you up and get you what you need. Especially I have to put in for the quizzes. Does anybody have any questions about anything? How was your class? All right, guys. Have a good day. I'll see you next time.
Bye,
Thank
Professor. Thank
you.
you.
Bye-bye. You guys take care.
You too.